Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. I'm Tom Bagwell, and it's good to have you with us tonight and in HD in New Orleans and Jefferson parishes for the first time in HD. So good to have you with us. Tonight we're going to be talking about the importance of having healthy bones and how a disease like osteoporosis can affect your overall health. Our guest is rheumatologist Tamika Webb-Detiege. In the second half hour of our program, we'll be taking your questions, as we always do, live by phone at 504-866-3200. That's 866-3200. And by email. You can email your questions to us, and you can do that right now at hhquestions@wlae.com. We'll ask you to hold off on the phone calls for just a short while. Well, tonight on the program, we do welcome Dr. Webb-Detiege. She has received her medical degree from the Temple University School of Medicine in Philadelphia. That's where she's from. She completed her residency in internal medicine at the University of Medicine and Dentistry of New Jersey Cooper Hospital before completing her rheumatology fellowship at Temple University Hospital. We're delighted to welcome back to the program Dr. Tamika Webb-Detiege. Nice to have you with us.
Thank you for having me.
Yeah, it's been about 5 years since you've been on the program. A lot has happened in your life, and lives themselves have happened, right?
Yes.
Yeah.
So I have a new baby who's a big girl now. She's 3 years old, Sophia, and I have a son, Quentin, who's now 6.
Very good.
And a husband to make all that happen.
And he's an emergency room physician, right?
Yes, at LSU New Orleans.
Okay. And what are remind me, it's been a while, what do 3-year-old and 6-year-olds do?
They play a lot. They watch Ninja Turtles, My Little Pony, and they fight.
And either one showing an interest in medicine at this early age?
Well, they say they're going to be doctors, but we'll see what happens.
All right. Well, tonight's topic is osteoporosis, so let's start with a definition, as we always do. What is osteoporosis, and how does it affect the overall body?
Well, osteoporosis, it's a disease. It's common, it's serious, it's preventable, and it's treatable. Osteo means bone, porous means holes, and basically you have damage to the bones that leads to weakening and risk for fractures.
Okay, and we can show what a patient looks like through the various stages of osteoporosis,
So this diagram basically shows a woman about the age of 50, and she has great posture, but as time goes on, she's developing fractures in the spine that cause her to bend forward, and at the end of that picture, she's probably about the age of 70.
All right, you've also brought a picture along to show us what osteoporosis looks like in the bone.
Okay, so the top picture is normal bone, and you can see that in comparison to the lower picture, the top bone picture shows thickened bones, not as much space, but when you look at the lower one, you can see that it is thinner in areas, there's more pores to it, and that structure is going to make a person more likely to fracture.
Okay. Are there some bones in our body that are more likely to be thinning bones, and they're going to cause fractures at some point.
Definitely. With osteoporosis, you can have a fracture in any part of your body that you injure, but the most common are in the hip, the vertebrae, that's your spine, and the wrists.
Okay. And how do these fractures typically occur?
Well, most commonly, your fractures are going to come from falls. So when a patient falls, if they have osteoporosis, they're at risk of fracturing their hip, their wrists, and in terms of the vertebrae, the spine itself, you can fracture that without an actual fall. I've had patients who've coughed, who've turned, who've picked up something and had a fracture as a result of that. So you don't have to have trauma to fracture the spine.
Okay. You started off by saying it's common. How common is osteoporosis? Who gets it?
Well, osteoporosis is a disease that's more common as you get older, and it's a serious issue. About 28 million people in the United States have it, and within each year we have about 1.5 million fractures that occur in the back, the wrists, and the hips. And just to put it in perspective, we talk a lot about breast cancer, heart attack, and stroke, but the rates of fracture each year are more than all of those together combined.
So the impact on the healthcare industry must be staggering.
It is, and it's not just a financial impact, it's an impact on the overall health of a person. And so, we talk about how common it is. 1 in 2 women will have a fracture after the age of 50. They say 1 in 6 men will have a fracture after the age of 50. When you have a fracture, most people will say, well, I'm at risk for fracture. Maybe if I wait and see if it happens, then I'll treat it. But the problem is if you wait to see what happens after you treat it, you may not return to your pre-injury status. So about 70% of people with osteoporosis who fracture, they don't go back to their usual state of health. And it costs about $17 billion, they calculated in 2005 alone, to care for these people once they fracture, surgery, hospital, and then long-term management. And it's projected that over the next 2 decades, 20 years, it's going to cost $474 billion. So it's a big cost to the healthcare system here, but it's also a big cost to patients because you get pain, disability, they may not be able to go back to work. And what we all worry about when we get older is not being able to live at home. And so 20% of people who have hip fractures end up in nursing homes.
Okay. You said it is a disease impacting older folks for the most part. At what age do you typically start to see osteoporosis?
So our bone is living tissue, and all throughout our life is changing. So we have cells that make it grow, and we have cells that break it down. And while you're growing, there's more of the cells that are building up, they're more active. And so your bone gets bigger and bigger. But by the time we reach the age 25 to 30, we've reached our peak. And after that, the cells that break down bone are more active. And so you start to lose bone density. And so after the age of 25, 30 is when we're going to see the changes. And so it's important for us to develop excellent bone health during childhood so that we're going from strong bone and we have more to lose than starting off with weak bone.
Is that going to be the same for everyone? I mean, some of us grow older quicker than others. We're the same age, may be the same age, but we're healthier than others. So does the bone start to break down the same for everyone at those ages?
So the change in the production is the same for everyone, but for those people who were healthier, who were more active, who developed stronger bone, if they lose 5% of their bone density, that's not as big of a deal if you started off with thinner bones because you didn't eat properly, you didn't exercise.
All right. You said you don't want to wait too long to be treated. So what are some of the common symptoms for someone with osteoporosis, preferably before the break?
So honestly, there are no real symptoms of osteoporosis. It's a painless disease. So you're not going to say, my back is thinning, I can feel it. You won't feel it. But what they say is that tooth loss can sometimes be a sign that there's osteoporosis. And in fact, the theory is that it's the jawbone being affected by osteoporosis, and that's leading to the loss of teeth. 1/3 of women in the U.S. lose all their teeth by the age of 60, by late 60s. I'm not looking forward to that at all. So the goal is to prevent osteoporosis so you don't have to experience that.
What are some of the major risk factors for osteoporosis? And just by the answer you just gave, I'm suggesting perhaps women more than men.
Women more than men, but we have risk factors that are things you can change and things you can't change. The risk factors that you can't change is just getting older. We're all going to get older. It's the way life is. Your other alternative is to pass away, right? So we're all going to get older, and as we get older, it's a risk factor. Your race. For non-Hispanic whites and Asians, they have higher risks of osteoporosis, so you can't change that. The way your body is built, in terms of your family, if you're a small structured family, you have more fractures. And then family history is a big thing. So if your grandparents, your parents had osteoporosis and they had fractures, or you have a sibling who also had a fracture, then you're at increased risk. So it's important to know your family history as well to know where you fall. But for yourself, if you fracture with a low-level injury, you trip and fall and you break your ankle after the age of 50, that may suggest that your bones are thinner than they should be and that you're at risk for osteoporosis.
Okay. I would not have put these two together, but drinking and bone density is an issue, right? Alcohol.
Yes, alcohol definitely is an issue. Alcohol use, cigarette smoking is a risk factor. In terms of alcohol, we worry about both the quantity and just the use as you get older, because you have the risk of falling in general because you're off balance as you get older, but when you drink alcohol, it increases the risk. Alcohol not only makes you a little dizzy if you drink too much, but it also can cause the liver not to function as well and produce the vitamin D you need for your bones. It also can decrease the amount of calcium absorbed by your stomach, and so it plays an important role, drinking alcohol.
Not pushing alcohol here, but we've heard from some guests on this program that a beer a day or perhaps a drink a day or a glass of wine a day may not only be not bad for you, but may be good for you. Are you suggesting that that's not the case when it comes to a bone loss?
No, I'm not suggesting
Okay.
that. It's really excessive alcohol, and
Okay.
excessive is defined as more than 2 drinks a day. And a drink is considered a 12-ounce beer, a 5-ounce glass of wine, or 1.5 ounce of liquor. So if you do more than 2, 3 or more in a day, then that's too much for your bone health.
Okay. Any commonly used medications that might create some issues with our bone development?
Okay, definitely there are some medications, but one thing I wanted to mention is things like the way we eat in terms of anorexia and bulimia. When patients have anorexia, bulimia, their bone density is much lower as well, so you have to be careful with that. And that's a lifestyle issue, but also the medicines you take are a lifestyle issue. So if you're someone who has a disease that requires you to use steroids, then you're definitely at a high risk for osteoporosis. If you have a thyroid disease and you're taking too much thyroid hormone, then you're at risk as well. A lot of people have things like acid reflux and they take what we call proton pump inhibitors. So that would be your Nexium, esomeprazole, Prilosec, omeprazole, and they decrease the absorption of calcium as well. And there are several more on the list as well. If you have breast cancer and you have to take breast cancer medicine, some of them will thin your bones as well. So you have to know what you're taking and work with your physician to make sure you're monitored.
And you mentioned hormone altering meds.
Definitely,
well, right? Okay.
Definitely. When women are experiencing things like breast cancer, they take medicines that help to control the cancer itself, but sometimes it increases the turnover of your bones, and so you have to be careful with that. Also with medicine used for prostate cancer in men called Lupron, that can increase the risk of osteoporosis.
Okay. Any other diseases that might impact bone health?
Well, definitely. Not a disease, but what everyone goes through. As a female, you go through menopause and your estrogen levels go down, and so you're at risk for osteoporosis as your estrogen levels go down. But in terms of actual other diseases we think about, having hyperthyroidism, again, that thyroid hormone being overly produced can thin the bones. Hyperparathyroidism, your parathyroids are 4 little glands that sit in your thyroid, and they control your calcium and vitamin D in your body. Cushing's disease, that's when you have too much steroid hormone in your body, and that can lead to osteoporosis as well. And I mentioned diabetes. Diabetes can definitely be related to osteoporosis.
Okay, and we have on the screen diabetes type 2, but also diabetes type 1 can also be an issue.
Definitely. Right? Type 2 is, with the increase in weight and population, in our population, we have a lot more people with type 2 diabetes, but we have patients with type 1, and so they also have the osteoporosis and bone changes as related to that.
All right. Well, we've all heard from the days growing up, 3 glasses of milk, so we know calcium is important for bone development, and vitamin D, and we're learning more and more about that. So what is the right amount of calcium and vitamin D, and where should we be getting those two?
It's a very good question. A lot of people ask this question. As you get past the age of 50, it's recommended that you get at least 1,000 milligrams of calcium a day. Some people say 1,200 to 1,500 milligrams. And it's really recommended that you get it from your food. Your food, such as milk, as you mentioned, your dairy products. There are extensive lists on the internet that will tell you where are great sources of calcium. Yogurt, things like sardines and salmon. It's really the bones that are in there that's the source. So there are different things that you can eat that will give you calcium, and there's some sources for people who are vegans who don't want to do dairy products where they can get calcium as well. Vitamin D, it's recommended that you get at least 800 international units, but we'll say about 1,000 once you get past the age of 50. Now, we used to get all of our vitamin D from the sun, but the risk of skin cancer has lowered how much people go out into the sun. And so vitamin D deficiency is a big issue in the United States. So we recommend that you take a supplement because it's hard to get it from your foods, and we try to avoid the sun to avoid skin cancer.
Right. I love putting our doctors on the spot, but always with permission. So how do you get your vitamin D?
Well, I try to eat well, but I also know that sometimes I don't do the best. And to be consistent, I take a multivitamin with vitamin D in it and try to make sure that it has at least 800 to 1,000 international units in it.
Vitamin D2, vitamin D3, and I'm hearing more and more good things about vitamin D3. Is that now the recommended because of the absorption process?
So there is evidence that D3 is absorbed better than D2. And so when we give the prescription, it's usually ergocalciferol and it's vitamin D2. But some patients will not absorb it as well and their levels won't increase. So if your vitamin D level is not increasing on D2, you switch to D3 and see if that absorption improves it and improves your levels.
All right. We're going to be talking about screening and treatment and prevention in just a moment, but we want to invite you to call us right now with your questions about bone health and osteoporosis. Our phone number is 504-866-3200. That's 866-3200. Again, you can call with your questions right now, or you can send us a question by email at hhquestions@wlae.com. Before we get to our viewers and their questions, let's talk about the screening process. How do you diagnose osteoporosis?
So our goal is to not diagnose it based on you having a fracture. So we want to diagnose you before you have any issues. There's something called a DEXA scan, a dual energy X-ray absorptometry. And basically what a patient does is they lay on the table, and it's almost like an X-ray, but it's less radiation than an X-ray. It takes an image of the lower spine, the lumbar spine, and the hip, and it can measure how thick the bones are. We ask that people get bone densities at least by age 65 in women. And in men, age 70, we start to do it. But a lot of times we'll do baselines after menopause to see where the bone density is and give recommendations.
Is this something that would be a primary care physician would recommend?
Definitely.
Okay.
Primary care, and for the women, the OB-GYNs will do it to keep it under control, along with mammograms, they'll do that. At
a certain age, would someone begin seeing a rheumatologist, or would that someone have to be referred to a rheumatologist only if there are issues?
Definitely. If you have issues, your primary will refer you, but usually they work it up and kind of get the ball rolling.
Okay. So I've been diagnosed, not in this case, but a patient has been diagnosed with osteoporosis. What are the treatment options available today?
So we have different treatment options. Most of the treatment is toward preventing resorption or breakdown of the bone. And we use bisphosphonates. So if you've watched TV, you've seen things for Fosamax, you've seen Sally Fields promote Beniva. And so these are medicines that are slowing down the breakdown of bone. Then we also have patients who use hormone replacement. So that's estrogen in women. There's a medicine called raloxifene. It's a SERM, selective estrogen receptor modulator. It works a lot like estrogen. And then we have teriparatide, which is Forteo. That's a daily shot. That one is more of an anabolic agent. It helps to build bone. And it's more of a last resort when the other ones don't work or you have contraindications to them, because it's an everyday injection and most patients don't like to do a shot every day. And calcitonin melatonin is a pill or can be a nasal spray, and it helps to build the bones. It's not as strong as the bisphosphonates, but it's helpful.
Okay. Well, the bad news is we are all going to get older and are getting older. The good news is that osteoporosis in many cases is preventable, right?
Exactly. Exactly.
And how can we prevent it? What can we do today?
So right now, the way you prevent osteoporosis is just the way you live a healthy life. The same thing that a heart doctor is going to tell you is the same thing I'm going to tell you. You need to avoid smoking, avoid heavy alcohol, and you need to exercise and stay active daily. Basically, what you want to do is to maintain your activity. You don't want to become someone who stops walking, who stops exercising, because your bones will continue to break down the less you move. So if you're immobile, you're at risk for osteoporosis. You also want to make sure you're getting adequate calcium and vitamin D, and those things will help to protect you. And that you get screened. That's how you prevent.
Okay. I know you wanted to offer some tips on for folks with elderly parents or grandparents who are worried about them falling, which is obviously the biggest risk factor with someone who has osteoporosis. We're also going to ask our viewers to call. If you have elderly parents or grandparents and you're doing things around your home that aren't mentioned by the doctor tonight, feel free to call us with what you're doing around your house to keep your parents and grandparents safe, worried about falling. But what tips can you pass along?
Well, you know, the tips are for really everybody, because you want to start to live this way. We have a big population of baby boomers. You want to make the modifications before something happens. And so what I usually recommend is that they make sure they have a flashlight by the bedside, so that if they have to get up in the middle of the night to go to the bathroom, you won't have to worry about tripping over anything. You can see where you go. We usually recommend that you make sure you don't have any extension cords or any phone cords along the floor, so you don't want to trip over them. You also want to make sure that if you're wearing shoes, they like to wear these open-toe slippers, open heel slippers. Mm-hmm. Those can come off when you're walking. I recommend that they wear shoes that your whole foot goes into it. It decreases your risk of falling, and that they use shoes that have a no-slip bottom. We also worry about when patients have issues with medicines that they take. So if you know a medicine causes you to get dizzy, you want to be careful and follow up with your primary doctor and try to avoid using those medicines if possible. Regular eye exams are important, so that you know your vision is good and you see what's going on there, so you don't trip over anything. So those are some simple things to help prevent.
Just as you're running down the list, I'm thinking bed height, maybe, that when you're younger, easier to roll out and get out, step down. When older, maybe not.
Well, apparently before there was this big popular thing about the high beds, and so now that all my patients are getting older, they're saying, my bed is too high, I have trouble getting into it. So your goal is to try to keep it low enough so that you're able to get in without any difficulty. I don't really like that some of my patients use little step stools to get into the bed. That's just another thing to trip over when you're getting out.
Right. Well, we've got some resources to pass along to you. Let's take a look. This is for the Arthritis Foundation and to learn more about osteoporosis. So let's give you those websites right now. Here they are. Arthritis, www.arthritis.org. That is the web address for the Arthritis Foundation. And rheumatology.org will get you in touch with the American College of Rheumatology. You can learn a lot more about what we've discussed tonight at both of those websites, and we'll pass those along to you at the end of tonight's program. Again, the time to call with your questions is right now. 504-866-3200 is our number. Plus, we'll have that at the bottom of the screen here in the second half. That's 504-866-3200, or you can email us your questions at hhquestions@wlae.com. Our guest is Dr. Tamika Webb-Detiege, and we'll be back with your questions in a moment. This is Hello Health on WLAE.
I need help finding a doctor.
PACE.
I needed help with my medication.
PACE.
I needed help getting around.
The Shirley Landry Benson PACE Center is a place that helps seniors remain in their homes, providing the care they need. If you or a family member are over 55 years old, you may be eligible for benefits offered by PACE. For more information, contact us at 504-835-0006. PACE, caring for those who cared for us.
They say that when you're facing extreme danger, your life flashes before you. If you think that's sad, consider facing it before you even have enough life to flash before your eyes. Deaths and injuries can be prevented by using the right car seat. Visit safercar.gov/the right seat to know what is appropriate for each age and size.
Welcome back to Hello Health on WLAE. I'm Tom Bagwell. Good to have you with us tonight. We're talking about osteoporosis and other issues related to bone health with rheumatologist Tamika Webb-Detiege. And we want to invite you to call us with your questions. Our phone number 504-866-3200. That's 504-866-3200. We do have phone lines open. Let's go to line 1 where Antoinette is with us tonight. Excuse me, we have Leslie on line 2 this evening. Leslie, welcome to Hello Health. Thank you for your patience. Leslie, are you there?
Yes, hi. I was wondering if there could be a little discussion on the side effects and the negative effects of bisphosphonates.
Okay, let's see, doctor.
So definitely there are some negative side effects with bisphosphonates. The problem is that the risk of a fracture way outweighs that risk. So some of the side effects we talk about are things like acid reflux when you take the pills. That's why we encourage that patients who have any issues with acid reflux let us know beforehand, because the oral pills can actually be given instead as an IV. So besides the GI or gastrointestinal side effects, we get concerned about things like osteonecrosis of the jaw. So osteonecrosis of the jaw is breakdown in the bone of the jaw. That's more common in patients who have been given the medicines at higher doses because they have a cancer that's affected the bone. Also, it's higher in people who have dental issues. So when we meet people and we know that they need to take this medicine, we have them see their dentist and make sure the dentist approves of them taking it, and that they're not going to have any new dental procedures coming up. Another risk factor that you may have heard about is if you take the medicines for long periods, sometimes it can cause atypical fractures. And usually what we'll say is it's an atypical fracture of the hip. And we'll say if you take the medicine for 5 years, you stop it and you just get monitored with the bone density that we talked about. And if your bone density goes down again, you decide whether to reinstitute the medicines. So those are the biggest side effects that we talk about with the bisphosphonates, things like Fosamax and Beniva.
Okay.
Does that answer your question?
Somewhat, but let's address the side effects that, various women say that they get flu-like symptoms when they first take a bisphosphonate, and sometimes even when they stop it, those symptoms do not go away. But more importantly, what are the bisphosphonates doing? Are they increasing the turnover? As far as the production of new bone, is it only something that is occurring as long as you're on the bisphosphonates? I mean, they seem to be somewhat of a very controversial drug.
So they do have risks, and so no way am I neglecting that they have a risk. When you talk about the flu-like symptoms that people experience, usually that's more so with the IV infusion. If you know about the one called Reclass or zoledronic acid, where you get 1 year worth of medicine as an infusion and you don't go back for another year. And some people will experience flu-like symptoms. I very rarely have had the people who take the once a week Fosamax or Lindronate have the flu-like symptoms. Now, in terms of how long does it last in your body, well, we know that the bisphosphonates last for a long time, and that's why we think that you can take it for 5 years and then stop it and then just monitor the bone density. So you have to decide what works for you. If you take that medicine and it doesn't work, you have side effects, we have other options. The thing you have to realize is that the other options also have side effects, and some of those are a little bit more complex. You may have to take it as every twice a year infusion. You may have to do subcutaneous injections daily, which most people don't want to try. So we tend to start with the oral medicines that you take once a week.
Leslie, is this something you have tried, or have you been diagnosed with osteoporosis?
No, I've read too much on the medicines and
would not try them.
And have you been diagnosed with osteoporosis?
Osteopenia.
I'm sorry?
Osteopenia.
Osteopenia. Yeah, penia,
Osteopenia means that the bones are thin, but they're not at the level of osteoporosis on the bone density. The problem is that there is also a risk of fracturing. Most people who fracture are people with osteopenia. And so what we use is something called a FRAX calculation. It's a calculation that you can do based on your bone density scores, and it'll tell me over the next 10 years what's your risk of fracture, and if that fracture outweighs the risk of taking the medicine. And those people who have a higher number are the people that we give the medicine to, because that risk of fracture is higher. You know, I understand people's concerns, but my biggest concern is when I see someone in a hospital who's fractured and now has to go to a nursing home and they can't live the way they're used to living. And so that is my biggest concern, is preventing people from losing their function and their independence.
All right. Leslie, thank you so much for your call tonight and for your concern. And Doctor, I'm glad you brought them up and answered them. Let's go to line 3. BK is calling us. BK, welcome to Hello Health.
Thank you. She answered my question with something similar to Lisa's, but I have a second question. How does it affect the disc in the back if you develop it?
So your question was, how does it affect the discs in the back?
Yes, in the back.
Okay.
Yeah.
So the discs are not a part of osteoporosis. Osteoporosis is the bone involvement. The disc is that basically like a gel-like structure in between the bones. And as you get older, those will dry out and people will lose height as a result of it, but that's not a part of osteoporosis. That's degenerative spine disease. That's a whole different concept.
And something we talked about on our last program. So thank you very much, BK, for your question. Let's go to Metairie, line 1. Lois is with us this evening. Lois, you're on with Dr. Tamika Webb-Detiege.
Thank you. I am 79 years old, and I have hypothyroidism. And for 55 years, I have taken medication for it. And when we first started taking the medication, it was a steroid. And I'm also having acid reflux. Now, I've just gone back to, I have started taking medication for osteoporosis. What are my chances of having it where I could get it up again and I don't have to take medication?
So the question is, what's the chances that your bone density will improve and you can get off of the medicine?
Exactly.
Okay. So, you know, you're constantly going to be losing bone just as we age. And the goal of the medicine is to slow that down. There's a good chance that it will, but you'll have to have the bone density repeated. And we usually will repeat it in 2 years after starting the treatment to see if the bones have stabilized and have they increased in density. If they increase in density beyond the level of osteoporosis, sometimes your physician will say we can hold it for now and monitor your bone density and then decide if you need it again. There's a good chance if you're taking it properly that it will help. But if it doesn't make a difference, then the doctor needs to make the decision to use a different medication so that your bone density will improve.
Lois, thank you very much for your call tonight. Our phone number is 504-866-3200. That's 504-866-3200. You can also send us questions by email at hhquestions@wlae.com. We'll stay in Metairie and go to line 2 where Marie is next. Marie, you're on with Dr. Detiege.
Hello.
Good evening.
Hello?
Good evening. Go right ahead, Marie.
It's Mary.
Oh, Mary, I'm sorry.
I was taking Fosamax, and it didn't seem to be doing much good. So then the doctor gave me Prolia, and you didn't mention that anything about Prolia. What are your thoughts about Prolia?
So I mentioned Prolia, but I mentioned the generic. It's teriparatide. Prolia is a parathyroid hormone analog, and it is given every 6 months as an injection, and it can be used when the bisphosphonates, that's your Fosamax, Beniva, don't work as well for you, or sometimes we'll use it when patients can't take those medicines because their kidney function isn't as good. And it does work as well. It can have the same side effects as the Fosamax and the Beniva, but the good thing about it is you take it as an injection. You don't have to worry about it being absorbed in your stomach. You don't have to worry about acid reflux. So it is a good alternative as well. It's newer, but it does work.
Mary, thank you so much for your call. Let's go to line 4 in Slidell on the North Shore. Phyllis is next. Phyllis, you're on Hello Health.
Hi, my question is basically people with autoimmune disease, how important is it to get this testing?
So I guess what I'm gathering is that you have an autoimmune disease. Which specific autoimmune disease? Because it differs.
I have the thyroiditis or Hashimoto's.
Okay, so there are different types of autoimmune diseases, and the diseases that I treat, things like rheumatoid arthritis and lupus, those patients have increased risk because there's more inflammation, and it leads to bone loss, and the medicines we use can also lead to osteoporosis. In Hashimoto's thyroiditis, so that's a thyroid disease, the main thing is you're already working with an endocrinologist. What they usually will do is make sure your thyroid hormones are normal, and if they become abnormal, they'll monitor them and adjust your medicines. It is important that you have a bone density as a baseline, and that if it's low, that they follow it regularly. But using an endocrinologist, they treat osteoporosis as well, and they'll be able to check that for you.
Phyllis, thank you so much. At what point should a patient with their primary care physician get a baseline? Should we wait until we're 60, or those ages you talked about, 65 or 70?
So for women, they'll say after menopause, you can get a baseline and see where your bone density is, because it's only going to get lower from there. Right? Because you're losing more bone. For men, they usually don't do them before the age of 70, but they will do them earlier. If you take a medicine that puts you at risk, like steroids, you're allowed to do a bone density for that. If you have other hormone issues like testosterone issues, if you have an unexpected fracture, they'll do bone densities as well to assess you.
Okay. Back to our phones. Line 3, Anna is next. Anna, you're on Hello Health. Good evening.
Good evening. I'm calling, you mentioned some of the questions I had about polio, and all I want to know is, can you take that if you've had breast cancer?
So, definitely your doctor needs to evaluate your history and what level of cancer you had to see whether they consider it more of a risk for you. There isn't an absolute contraindication. The one medicine we really say we don't like to give in patients who've had a cancer is the one called Forteo. And Forteo is an injection. It can lead to, and you know what, I need to correct myself because I said Prolia was teriparatide, and Prolia is actually denosumab, which is a rank ligand inhibitor. So I apologize to the last person. I realized that I said that incorrectly. So Prolia is denosumab, and Forteo is teriparatide. That's the one you cannot take if you've had a cancer before.
Okay. Anna, does that answer your question?
You can take it, probably.
Can take it, she said.
Yes.
Yes. And would your oncologist decide, or your
oncologist would get you connected, and sometimes they will do the management, or sometimes they will refer you out.
Okay. And the next question, once you take it, it's an injection. If you do have side effects, you can't stop taking it because it's in your system already.
Well,
how do they handle the side effects then?
It depends on the side effects that you have with it. You're right, you take it every 6 months, and so once you get that injection, if you had a side effect, it would be in your body and you would have to wait for that to wear out, and you would just not get the next 6-month injection. But definitely, if you had a problem with it, they wouldn't repeat it again.
And some of the side effects with this medication would be what?
Similar side effects. So some people say they get achy with it. You can have the jaw issue that they talked about, but it's at a lower rate than you would expect, but you still have that potentially there.
Okay. Anna, thank you for your questions tonight. Let's go staying in New Orleans with Emma on line 1. Emma, you're on with Dr. Webb-Detiege.
Yeah, hi, doctor. I need to know, I have a Lendronate, and it's once a week. I had in the beginning Fosamax, but it was for less than 5 years. It was maybe 2 or 3 years. Now, I am interested in getting Extortion. Extortion is a new medicine, and I wonder if it's good, if you ever hear of it.
So I need the medicine repeated again. What's the new medicine you're interested in?
Oh, the medicine that I would like to try is Extortion, Stortion. But the one that I'm taking right now with the prescription of my doctor is Lendronate, which is I think it's once a week.
So the
like
medicine.
Generic of Fosamax.
So alendronate is the generic Fosamax, and it's been around the longest and has the most data. And so you're going to have more information on side effects and potential issues. The medicine you mentioned, Strontin, I'm not aware of that being FDA approved. Where are you getting that medicine from?
No, I received a medical letter in the mail, 1 year subscription. It's a female doctor, and that's what she's recommending right now. But I had to have a doctor prescription, and I had to talk to my doctor. But that's just on the horizon. I'm not taking that. I'm taking what the doctor prescribed. Thank you.
Okay.
Thank you. And this is not something you've heard of yet?
Not being FDA approved now.
Okay. Thank you very much, Emma, for your call. Let's go to Jason, who's been holding patiently on line 6. Jason, welcome. You're on Hello Health.
Thank you. I didn't catch your program from the beginning, and I just want to ask you about Prilosec. Does that have any bad after effects after years of taking it?
Well, thank you. What we mentioned was that the use of those proton pump inhibitors like Prilosec and Nexium can influence the absorption of calcium in your stomach. And so there is a risk that it could be something that would lead to osteoporosis. And so it's important, if you're taking that medicine regularly, that you talk with the primary and you guys make the decision about when to check your bone density.
And what about Tums or other antacids that are not as strong as...
Well, Tums, some people take as calcium supplements because it has a high component of calcium in it. So the thought is that it may not affect the absorption in the way that a proton pump inhibitor would.
Okay. Jason, thank you for your call. Let's go to line 2. Jan is next. Jan, welcome. You're on Hello Health.
Yes, I'm wondering about the reclass. I've had that now for once a year for 5 years. Is there a maximum number of years in taking that as there is on the Fosamax?
Well, the thought is that it should be similar. And so what we say is that if you are not getting the results of the bone density in 5 years, then you need a different treatment, and it would be a different mechanism. And so what you should do is talk to your physician and go over your bone density. If it has not improved, then there needs to be something else used. And that could be in the lines of Prolia, which was mentioned before, or Forteo, the injections. And so that's a conversation you'll need to have.
Answer your question for you?
Just like the reclass?
So the reclass is like Boniva and Fosamax. It's a bisphosphonate. The Prolia is the one called denosumab, which blocks something called rank ligand and slows down the osteoclasts that break down the cells. And Forteo is teriparatide, which affects your parathyroid hormone levels. So they have different mechanisms. Does that answer your question?
It does, certainly. Thank you very much.
You're welcome.
Thank you for your call. Our phone number tonight is 504-866-3200. There it is on the bottom of your screen, 504-866-3200. You can send us questions by email too at hhquestions@wlae.com. Let's go to line 2. I believe Jan is next. Jan, are you with us? Excuse me, line 4. Patricia is calling us from Pearl River. Patricia, welcome.
Thank you. I wanted to know about the side effects of Prolia, and you said it was preventing the breakdown. So how can it ever build up your bones any denser than they are? So they would just stay at that level?
So that's a good question. Remember, I mentioned that there are 2 types of cells. There are cells that are breaking down bone, and there are cells that are building up bone. So if I control the cells that are breaking down the bone, the ones that are building up get a head start and get to move. And so it will build bone density. And you monitor that bone density by doing the DEXA scan, and you can see the changes in how dense the bone becomes with the use of the therapy.
Okay, and the other part of the question, what are the side effects of the Prolia, and are they very severe?
So again, the side effects can be similar to the bisphosphonates, Fosamax and Boniva. You worry about things like osteonecrosis of the jaw. Some people will say they have joint pains when they use the medicine, and so you monitor that when you're using the medicine.
And those are not given at 6-month and 1-year intervals?
The Prolia that she's mentioning is given in a 6-month intervals.
So there is that risk.
There is that risk. And the bisphosphonates, the Fosamax, Boniva, you can have once a week, once a month. You can do Boniva as an injection at longer distances, and you can do the once a year reclass.
So with the options that you can go once a week, once a month, if you're worried about side effects, better to start there.
Yes.
And see if there's side effects.
Definitely, and there's always limitations in insurance. The ones that are once a week are easier to get with your insurance because they're generic, and then the ones that's once a year, more difficult to get.
All right, good questions tonight. Thank you to our viewers. Let's go to line 1. Carolyn is next. Carolyn, you're on Hello Health with Dr. Tamika Webb-Detiege.
Hello, good afternoon, and thank you so much. Can you hear me?
Can hear you just fine, Carolyn. Go right ahead.
Hi, I'm 64 years old, and I have been diagnosed with, I saw it on your screen, spondylitis. I have that. I have severe arthritis, and I've just read recently something about estrogen and the E patch, and of course, from the old school, I avoided estrogen for so many years because of the study with breast cancer and all that. Now I'm wondering, could you tell us a little bit more about using estrogen, especially maybe the E patch? Would that be something that could help?
So that's a good question. Estrogen does help to build bone back up. The problem is like you mentioned, there are some studies that show that there's a risk of side effects and concerns. What we usually recommend is for younger females early on in menopause, that estrogen is an option. But once you reach getting into the age of 65, you're going to get more concerned about potential side effects. And so you have to weigh the risk of estrogen with the benefits. And so usually the gynecologist would prescribe that. We don't prescribe estrogen, and they'll determine whether it's a safe mechanism for managing your osteoporosis.
Carolyn, does that help?
Well, I don't see a gynecologist anymore. I do see a primary care physician. Would I go to a rheumatologist now to help me with these challenges that I'm having?
So most rheumatologists do not prescribe estrogen. So you're going to start with the primary, who will decide if either A, they want to prescribe it, or if they want you to have a good exam to make sure everything is normal before you add hormones to it.
All right, Carolyn, thank you so much for your questions tonight and your call. Let's go to line 3. Carmen is next. Carmen, you're on Hello Health.
Yes, my name is Carmen.
Good evening.
Thank you for taking my call. I do have osteoporosis, and I also have acid reflux. And right now, I'm taking the Prolia intravenous in my arm, but I've only taken it once so far, and I'm waiting to take the next 6 months. Is that okay?
So you have osteoporosis and you have the acid reflux, and so you're doing it the IV way with the Prolia, correct?
Uh-huh.
And yes, that time span every 6 months is the correct time span for the Prolia. So it's a good option because it doesn't interfere with your stomach, and you don't have to worry about having heartburn issues with it. So it's definitely an option for you. The next step would be to get your repeat infusion, and then you'll have to decide with your doctor when to repeat your bone density to see if it's helping. Usually we say 2 years or so of treatment and then repeat the study.
Okay, Carmen, thank you so much. Our phone number is 504-866-3200. That's 866-3200. We're still open for email questions, too, at hhquestions@wlae.com. Looks like we have some phone lines open, too. Let's go to line 2. Jeanette is calling us from Harvey this evening. Jeanette, you're on Hello Health. Nice to have you with us.
Thank you. I had a bone density test in 2002, and I am now 76 years old. Do I need to have another one? How often do you get one? And who do I go to?
So, question for you. Was your bone density normal in 2002?
I don't remember.
Okay.
In 2002, I don't remember. seems like it was good then.
Okay, so that's a pretty good distance between the previous one. So it definitely is a good idea for you to get a new one and see where the bone density is now. Your primary doctor can order that for you. If you're still seeing a gynecologist, they can do that as well for you. But you should get one done and then see where you fall. If the bone density is normal, we'll say don't repeat it for another 4 to 5 years. If it's thin, then we'll talk about whether you have a risk and need treatment. And then usually if you need treatment, or even if you don't, but the bones are thin, we'll repeat it every 2 years.
So Jeanette should go get tested.
She should definitely get tested.
All right, Jeanette, thank you so much. And again, what are the age groups where most physicians will start to take these bone tests?
So postmenopausal, right after you go through menopause as a woman, they'll take a baseline. Age 65 is when the insurances will allow you to get the bone density done without excessive cost. And then that's for women, and age 70 for men. But again, if you're on a steroid, we can do them before then just to see if you have certain diseases. We can sometimes do them a little bit earlier.
Yeah, and extenuating circumstances, early breaks, things along those lines.
We'll make you a candidate to get it done.
All right. 504-866-3200 is our phone number. We do have some email questions, too, we'll try to get to. But let's go to line 1 now. Wilhelmina calling us from New Orleans this evening. Wilhelmina, welcome. You're on Hello Health. Wilhelmina, are you there?
Yes, I'm here.
Go right ahead, ma'am, with your question.
Yes, hi. I don't know if she can help me or not, but I just was trying to get some answers about fibromyalgia pain.
Not particularly the topic tonight, but doctor, you want to take a stab here?
Well, you know, it's a complex condition, fibromyalgia. It's when you have aches in your muscles, and basically what you need to do is you need to see your primary care doctor to start off to make sure that fibromyalgia is the source of the symptoms, because sometimes you can have those symptoms and it actually be related to something else. So it's important to start with the primary doctor and get a good, thorough evaluation. Osteoporosis is not going to cause you to have pain unless something is fractured, and fibromyalgia does not lead to osteoporosis.
Okay, Wilhelmina, thank you for your call. Let's go to line 2 in Kenner, where Helen is holding. Helen, you're on line 2 and you're on Hello Health.
Yes, thank you for taking my call. My name is Helen. I am 77 years old. I took Fosamax for 10 years. And right now, I'm taking Evista. I wonder what your opinion is on Evista. I have been on Evista for 2 years, and the last bone density was the same as 2 years ago. In other words, Evista has stabilized it at the same level. I have osteopenia now. I used to have osteoporosis. So what's your opinion on Evista, please?
So Evista, that's the one that's raloxifene or SERM that I mentioned, selective estrogen receptor modulator, and it does help with osteoporosis. The thing is, once you get past the age of 70 or so, sometimes we don't like to use it as often. Now, it sounds like you're getting good results from it, and there was a reason why your doctor switched you from the bisphosphonates to that. The fact that your bone density is staying stabilized, I think, is a good sign. And so what I would recommend is that you have another bone density 2 years from the last one, and then make a decision. And that along with your physician, you go over the side effect profile and make sure that it is something that you're willing to continue with.
All right. Our phone number, 504-866-3200. But doctor, let's get to some email questions we've received. Doctor, would you explain the difference between osteopenia and osteoporosis? You've done that a little bit, but go into a little more. And also the treatment options and types of exercises to strengthen bones. This is from Linda. Linda, thanks.
So it's a really good question. Osteopenia means the bones are thin, but not at the level of osteoporosis. Osteoporosis is defined on your bone density as a T-score of -2.5 or more negative. So if you are between a -1, but just before a -2.5, you're considered osteopenia. And that group is really the biggest group that has fractures, so it is a risk factor for having a fracture. What we do is once we get that score is we calculate what your risk is of having a fracture over the next 10 years with something called a FRAX calculation. And then that tells us whether you need to be treated or not. Now, the types of treatments, we talked about the different medicines that you can use, but in terms of types of exercises, we always encourage regular walking, weight-bearing exercises. Walking is a weight-bearing exercise because you're up and moving. We recommend light weights, whatever you can tolerate to help to build the bones up as well. Anything that keeps you moving and mobile, because when you exercise, your balance is going to be better. You're going to build up your bones and your muscles. You're going to be less likely to fall. And so it's helpful.
And you're looking at low impact exercises, especially for folks who are older?
Definitely to start off with, but you listen to your body. You know, if you're able to do a little bit more exercise, if you're able to jog a little bit and not just walk, you do what your body allows you to do.
Okay, let's go back to our phone lines. Line 1, Yolanda calling us from Marrero this evening. Yolanda, you're on with Dr. Tamika Webb-Detiege.
Yes, good evening, and I'm glad y'all can take my call. My question for the doctor is I need to know, my doctor has informed me that my bones are deteriorating in my hip, not just one of my hips, but both of my hips. And I'm 53 years old. I'm in therapy, and therapy helps, but I need to know, is there anything that I can do to stop the process of my bone deteriorating in my hips? I'm so young, and he told me I'm going to have to eventually have not one hip replacement, but two, and my left hip bothers me a whole lot right now.
So that's different than osteoporosis. When they talk about deteriorating bones, they're talking more about arthritis, so osteoarthritis or degenerative changes in the hips. And one thing you can do, depending on your body mass, if you lose weight, it'll decrease the pressure on the bones, and that can slow it down. But the damage that's there, you really can't reverse that. So the goal is to maintain a healthy weight so that the damage doesn't occur in the first place. And then once there is damage, to try to keep the weight in such a level that it doesn't put more pressure on it.
Okay, Yolanda, thank you so much for your question. Let's go to another email. Doctor, I'm 58, was diagnosed with osteoporosis about 2 or 3 years ago. I declined medication because of the side effects, and we've talked about those tonight. I've had 2 or 3 bone scans, and I've been confused with scale of how extensive the disease is. Would you please explain the scale that measures osteoporosis? And we did just touch on this, but let's do it again.
So again, osteoporosis is defined by the DEXA scan as a T-score of minus 2.5 or less. And so we'll consider anything above that as osteoporosis and more severe. So the thing
above meaning
more
3?
negative,
Okay,
negative
so
-3, -4,
okay,
-5. And so when you start to get towards those numbers, we'll sometimes call it severe. But really, it honestly doesn't matter, because remember we said that with osteopenia you can fracture. And so if you have really bad numbers, you're at a higher risk of fracturing, but you don't want to be lulled into a sense of security because you're just a little bit osteoporotic. You can still fracture. And so it's important to know your numbers, but it's also important to know that you can fracture at any number.
Okay. And it seems like most of what we've talked about tonight is holding on to what we have. Is there anything on the horizon, any studies you're reading about, anything you're excited about, that if you were back on the program, hopefully before the next 5 years when you were here the last time, that we'll be talking about as exciting and breakthroughs?
Well, a lot of the things that are different basically work in the same mechanism. It's just avoiding some of the side effects. So we'll have to see if any of the newer medicines will make people more comfortable with using them.
Okay. I want to thank the doctor for her education and information that she's provided tonight, and for her work in the Ochsner Health System. Thank you so much, doctor.
Thank you for having me.
Great program and great questions from our viewers tonight. To make an appointment with any Ochsner physician, including tonight's guest, Dr. Tamika Webb-Detiege, or to register for any of Ochsner's Hello Health seminars, they take place almost every week across the greater New Orleans area. You can call Ochsner at this special number. It's a number set up just for viewers of this program, 842-5669. That's 842-5669 with an area code of 504. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com or on Ochsner's website at ochsner.org. Our thanks again to tonight's guest. Thanks to Humana and Ochsner for making our program possible. And our final thanks is to you for your support of our program and our station, WLAE. Good evening.
Hello Health on LAE is presented by the Ochsner Health System, a a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxnard Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxnard, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.